1 in 7 pregnant women, yes, 14% of pregnant women will be diagnosed with diabetes worldwide. And most of them don't even know it's coming. And could you be one of them? When a diagnosis of gestational diabetes does occur, it can genuinely change the trajectory of the pregnancy. I'm not exaggerating. And I want to discuss in this video why you need to know about this condition, especially because it's so popular, how it can change pregnancy, and what exactly you can do about it if you are affected. So do keep watching. I'm Remy, I'm an obstetrics and gynecology doctor with over 10 years of experience in the NHS. And I'm on this channel because I'm passionate about educating women, not only about pregnancy, but also about postpartum care. So subscribe if that's something that you're interested in. So gestational diabetes, what exactly is it? It's diabetes that you might see outside of pregnancy, so type 2 diabetes in the non-pregnant population, and it typically happens in the 2nd or the 3rd trimester. So by definition, it can only really happen after 20 weeks. And to understand why it happens, I really need to take you back to sort of basic biology, and I promise I won't bore you. But just think very loosely, very, very loosely, that you have sugar and that you have insulin. And sugar we get from things that we eat, we drink, and it gets stored in our body, into our muscles, it helps our fat, all of these things. It's a really good thing to have. But then you have insulin. You need insulin, so when the sugar goes into the blood, the insulin can delegate and push it to where it needs to be. When you have insulin resistance, so the insulin's not working very well, or the body's not able to produce enough insulin for the sugar that's circulating in your body, what you then get is sugar that's just in the bloodstream. And that's what we pick up as diabetes. So in pregnancy, the placenta itself does generate an insulin resistant state. And then what you get is that your body produces insulin and it still manages to deal with the sugar. But for some people, that just doesn't work as well. And what that manifests as is diabetes. And in the general non-pregnant population, I remember going through med school and they would say things like, the signs of diabetes are increased thirst or going to the toilet more. But you might not see that really in pregnancy. So in the course of this video, I will tell you how it's picked up, how it's detected in the 1st trimester, 2nd trimester, and 3rd trimester. And when it is picked up, what needs to be put in place for you to have a safe pregnancy and a safe delivery. So before you start beating yourself up if you have this diagnosis, you need to understand that there are some predetermined things that put you at risk of having gestational diabetes. When you're screening anyone in pregnancy, things the midwife or the clinician are particularly looking out for is, does this person have a history of gestational diabetes in a previous pregnancy? Because that will give you a risk of having it in your current pregnancy. Is the person overweight, so a higher BMI, especially 30, probably 35, because that again puts you at risk of having gestational diabetes. Has your family member had it either in pregnancy or outside of pregnancy? Do you have parents with type 2 diabetes? Because that will put you at risk also. And then there's specific ethnicities where we see clustering of type 2 diabetes in sort of South Asian, African populations, and therefore those people could be at risk of having gestational diabetes. And it's really important to note, which I will go on to discuss again later on, that if you have gestational diabetes in your pregnancy, you are at risk of having it in later life. And I have a video that details what that risk is and what you need to do once the baby is born. So these are the things that might put you at risk of developing it in pregnancy. But how exactly is it diagnosed? Like I said, I would tell you about the 1st trimester. So when you have that appointment with your first clinician, what they need to be doing at that time, they check your full blood count, they'll check other things like if you're at risk of getting infections in pregnancy. But what they also need to check is, are you someone that has already had a diagnosis of type 2 diabetes or already has pre-diabetes, or are you someone that already has diabetes but you didn't know, like it wasn't picked up before the pregnancy? And if that value was high or borderline, then you're going to be someone that's at risk of it in the later pregnancy. And there are things that they can do in the 1st trimester to be proactive, so get you testing your blood sugars already, or waiting for you to have the test that they would do for most people in the 2nd trimester. And I've had this test twice. I really dreaded it, but it is something that is necessary. So because I'm Black, African, I met the tick box for the NHS, I should caveat, in the UK, to be tested for gestational diabetes. And what the test involved is coming into the hospital without having anything to eat. So you have to come in absolutely fasted, right? And when you're pregnant, that's quite a tall ordeal, I think. It's really uncomfortable. But you come in having had nothing the night before. And then you get to the hospital and the first thing they do is do a blood test. So they'll take your blood at that point and then they give you a sugary drink. Now, when I was a student and I went around observing this test, what they used was Lucozade, because it had the right amount of glucose in it, 75 grams of glucose within the drink. Like, that's how the test is validated. And so now they've got like a sickly drink, but it has 75 grams of sugar. So you have the drink as quickly as you can, giving me shadows thinking about it. And then you sit for 2 hours doing nothing, just waiting. And then you have another blood test. And then once you've had that blood test, you're free to do whatever you want. And in that 2 hour window, you're not meant to eat, drink, or do any sort of strenuous exercise really, because that will affect how the values are read. So when you're thinking about diagnosing, there's a cutoff for the first blood test, the fasting blood test, and the 2 hour post the drink blood test. Because if the first value is high, that could tell us that you already have diabetes. And if the first value and the second value are high, diabetes. If the first value is normal but the second value is high, again, that's suggestive of diabetes. And that's how you diagnose it in the second trimester. So I have seen things online about people wanting to avoid the drink because of the toxins and things that might be within the contents of the drink itself. I wouldn't necessarily advocate for that, because actually the risk factors of having diabetes, let alone diabetes that's undiagnosed, can be really, really dangerous. And I will cover that off in this video also. But there are some people who don't know they have diabetes until the third trimester. And I see this really commonly in pregnancy. So for whatever reason, more people are having a scan in the third trimester, so at sort of 36 weeks. And the way that it could happen is that maybe someone has a bigger BMI, so therefore measuring the baby size on the tummy isn't going to be accurate. And they have scans from 32 weeks, 36 weeks, 40 weeks. Or, for instance, they are being measured on the tummy, and if the measurements are slightly off or slightly bigger, then they would go off and have a scan. And when the baby is scanned, the detection of a big baby at that time will lead you down the cascade of checking for diabetes, because it's really not uncommon for women to have gone through that glucose tolerance test and not have diabetes at that time. And then you fast forward to the third trimester, and then in fact they do have diabetes later on down the line. And that is still just as important that you want to pick up on, because I said I'll go into the risks of having diabetes. So when they identify a big baby, there are other causes for a big baby, but the cause that we worry about the most is diabetes. And once you're beyond 36 weeks, it's really not advisable to do that glucose tolerance test that I mentioned. Not only is it unpleasant, I don't think it's as accurate as if you were doing it beforehand. So then the method of diagnosis at that point is where you're checking your blood sugar levels, often with a finger prick or a glucose monitor, depending on the unit that you're in. And they're checking to see that your sugar levels are within pregnancy range. So what the sugar levels for someone who's pregnant versus someone who's not pregnant should be are very different. So for someone who is pregnant, where you've got a big baby and you're now concerned about diabetes and they're above 36 weeks, what they would do is then check their BM monitorings. So you want to do it fasted, so the first thing in the morning before breakfast, an hour often after breakfast, an hour after lunch, and an hour after dinner. And so checking for a week to see what the sugar levels are. And again, for someone who's not diabetic, you really do expect it all to be within range. For someone who is diabetic, you might get a few readings that are outside of range. And for that point, you would then intervene whether or not you want them to modify their diet or start some medication, which again, I'll try and cover off in this video. So if someone has a diagnosis of gestational diabetes because they've either been diagnosed in the first trimester, second trimester, or third trimester, what does it actually mean and what does it change to their pregnancy? So what you really want to do is make sure that the sugar levels are kept under control. So the first step is diet control. So this will often involve the input of a dietitian who would give specific advice around what dietary changes a woman can make, especially within the context of their culture, to achieve good sugar levels. I work in East London, so my population that I serve are more likely to be, again, Asian or African, and someone who's from a Nigerian background. When I'm speaking to them in the clinic and I'm like, okay, so what are you eating? So say you're eating pounded yam and soup, and that's what you're having 3 nights a week. And as you've done it, you can see that your sugar levels are high. At that appointment, I'm not going to tell you not to eat the food you want to eat. I'm just going to say, what about portion control? So instead of having a really big portion, why don't you half the portion that you have more soup, have more chicken, have more beef, have more protein? So to get the diet under control, you're going to speak to the dietitian. But every time you see a midwife or a doctor, that dietary advice really needs to be reiterated. And the idea is that you're swapping out like sort of the simple carbs, the freely sugary available carbs for more complex carbs, increasing your protein, increasing your veg. And I think it's really important that it needs to be done within the cultural context of who you're speaking to. And ultimately, once you've eaten, why don't you do a 30-minute walk, or even if it's 30 minutes around the house? Because again, what you're doing is you're promoting your body to make use of all that sugar and kind of helping your insulin out. So dietary advice is primarily the number one treatment option. So dietary advice with some exercise. And what you might find is that that's enough for a lot of women to really control their sugar levels throughout the pregnancy. What you might then find is that that's not enough. And when it's not enough, the next step is medication. So the first thing that would often be given, especially in the UK, is something called metformin, a drug that's used for diabetes. Some people use it for PCOS. I think I've seen it used in like longevity medicine. Still don't know why, I haven't looked it up. But metformin can be used, and then you would start off with a small dose and then titrate it up in accordance to the need of the patient. When you're being given the metformin, it isn't ideally just given to you as a blanket, but the person wants to have been looking at how your sugars behave over the day. So you might be someone whose sugars are quite normal, but at nighttime they really spike up. And then at that point, that's beneficial that you have the metformin then, or you spike in the morning and then they give you the metformin then, or you need like literally 24-hour coverage. So those are the things that need to be taken into account. And similarly, insulin. If the metformin has been used to the maximum dose and they're still not winning, then you can go on to insulin during the pregnancy to help control it. And what I like to think about is when you're being managed for diabetes is that you kind of have three management categories. Either it's diet, either it's medication, or either it's insulin. And oftentimes that category affects how closely you monitor the pregnancy. So someone who's really well controlled on diet might not need as much intervention as someone who's on medication, who might not need as much intervention as someone who's requiring insulin. So the minute you have that diagnosis, there really is benefit in you being super strict with your diet. And I say this, but I genuinely do think that having to restrict your diet during pregnancy is rough. Like honestly, restricting your diet outside of pregnancy is hard enough as it is, but in pregnancy, it's even, I honestly feel sorry for women. I honestly do. But having said that, if you can control your diet and your exercise so well that you don't need the metformin and you don't need the insulin, you're actually changing the trajectory of which the gestational diabetes affects your pregnancy. And I think that's really important to note. I've covered off the treatment categories and how specifically is treated, but like I did say, I will tell you how the gestational diabetes itself can complicate your pregnancy. And so we can do this in a few ways. We think about the baby, we think about you, and we think about your life after the baby. So for the baby itself, where the gestational diabetes exists, you have a ton load of sugar running through the placenta and you have a really big baby, or you have a ton load of sugar affecting the placenta and having a really small baby. And both of those come with complications. A big baby, if you think about it, over a certain amount, you may not be able to deliver vaginally. So you might see like random news stories of like a 5-kilo baby being born, or 4.5-kilo baby being born through the vagina. And these things exist, they're true. But the bigger a baby is, the more complicated potentially your delivery is. In addition, when someone who has diabetes and has a big baby is having a vaginal delivery, there's a risk that once the head comes out, the shoulders get stuck, and there's a difficulty with delivering the shoulders, which can be detrimental for the baby. Largely with practice, 90% of those babies will be born within 5 minutes of the head coming out, but there is always a risk of the babies being born needing help, not getting enough oxygen to their brain. So again, that could be quite complicated, and that's something that your medical team will want to discuss around your planning for delivery. One of the more serious things associated with gestational diabetes is the risk of stillbirth. So again, the idea is that the placenta itself just doesn't work as well when there is all that sugar around. And then what that means is that the placenta ages in a way that's slightly quicker than people who don't have diabetes. So thinking again about the treatment categories, if you're someone with diabetes that's managed with your diet, the idea in the UK, using UK numbers, that you should be able to get to about 40 weeks in 4 days and achieve a normal vaginal delivery without that increased risk of stillbirth. If you're requiring metformin, then you could go to about 39 weeks and 6 days. And at that point, that it's really recommended that you have a delivery at that point. If you're on insulin, the longest really that you want to be going is about 38 weeks and 6 days, but that will differ depending on how well your diabetes is controlled. If your insulin requirement is going up or going down, that might also indicate what the placenta is doing and how quickly the delivery needs to happen. And I don't say the risk of stillbirth to scare you, but it's something that we see in practice where someone might come in with a stillbirth. One might think that completely a surprise. And when you go back and start digging and going through the test results or going through the blood results, then there might be an undiagnosed gestational diabetes that has led to that. Not saying that happens all the time, but that's definitely something that I've seen in practice. So for that reason specifically, it really is important that number one, you get tested for it. And once you are tested, that you're monitored and the baby's monitored so that the timing of the delivery is like just right. If we know that the placenta itself is at risk of being faulty, not working as well, people with gestational diabetes are at high risk of having things like high blood pressure and a condition known as preeclampsia. And again, that leads to more intervention. And there'll be other risks as well, having too much fluid around the baby, which puts you at risk of having a preterm birth and on and on. But again, your individualized risk is something that I would reckon you need to discuss with your clinician. So that's largely the risks around the baby. Now, thinking about you, the person carrying the baby, if you get diagnosed with gestational diabetes, what does it mean for you? Like, obviously, I've mentioned how your pregnancy changes, the intervention changes, how your whole experience of pregnancy potentially changes. At the time of delivery, it increases the risk of you requiring a cesarean section, which again is a risk, I guess, that the mother has to carry, that you would have to carry. But then moving on from that, once the baby is born, by and large, if you are either on insulin, metformin, whatever you are, you no longer need to do it. Because the idea is that once a baby's born and the placenta is delivered, you are no longer someone who has diabetes. You are now you. In a small percentage, they will have persistent diabetes, but the majority will just go back to normal. But what happens once the baby's born is that at 13 weeks, you should have a blood test to see if you have persistent diabetes or to confirm that it's gone back to normal. But then after that, every year, you should be checking your risk of diabetes. And that's done with a blood test, which sees how much sugar circulates around your red blood cells. And I think ultimately what you have now is data. You have data that in a stressful situation where the placenta caused insulin resistance, that you are likely to get diabetes in pregnancy. But what it tells you is that actually maybe when you're 40 or 50, that you may well get diabetes as well, unless you make health changes in that time period. But also going back to the baby, a baby born in a sugary environment at birth is at risk of not knowing how to control their own sugars, so will be watched a bit closely by the baby doctors. And there's also evidence that they're also at risk of diabetes in their long-term health. So I think, again, when you have data, it's really good to do something with that information. What changes can you make for your own life now, but also what changes can you make for your growing child? So what you might expect in pregnancy once you have the diagnosis is the monitoring increases. So you get more appointments with the midwife, more appointments with the doctor, more scans for the baby. And you may well, depending on your treatment category, need induction of labour or a cesarean section in order to time the delivery appropriately, because we want to avoid that risk of stillbirth. If you're someone, like I'm seeing increasingly, is getting a diagnosis in your third trimester at 36 weeks, what you've probably done is gone your whole pregnancy with the notion that you're low risk. And at 36 weeks, someone says, oof, baby's big. And then you test for a week. And at 37 weeks, they're like, oh, there's diabetes. And then with that information, they're like, okay, we can manage you a diet because you probably only have a couple of weeks left. But say you do need medication, then at 39 weeks and a few days, then they'll be discussing induction for you. But you've now gone 36 weeks with the premise that nothing has gone wrong and you are fine. And then the last potentially 3 to 4 weeks of the pregnancy, it's now complicated by this idea of diabetes. And again, it changes really your notion of being able to either have a home birth, a midwife-led birth, and now up in the ante and putting you on a labouring suite where you're then managed by doctors and midwives. So that's how it can really change the trajectory. And the monitoring, like again, scans, checking your blood sugar levels and trying to tweak it and manage it and keep it under control. Those are all really vital things that are needed, and definitely something that I want you to engage with when you're going to see the doctors, the midwives, or going for your scans. Do not shy away from it, because that's really the only way that you can make an informed decision and stay on top of it. As you're drawing to the end of the pregnancy, as you're having your delivery and you're going home, don't think of it as something that's like completely disappeared, and make sure you're doing those checks that I've mentioned. But I also link the video in which I discuss it in more detail and what changes you can make to your lifestyle moving forward. You might be overwhelmed. I mean, I'm overwhelmed filming this video, but you may well be overwhelmed with the amount of information that was on this video. And so if you have any specific questions, please link them in the comments down below and I will answer them. I answer all comments. But I hope you've learned what diabetes is, when and how it can be diagnosed, how it might change the trajectory of your pregnancy, and exactly where your empowerment lies through it. If you have had gestational diabetes and you had a specific experience, why don't you share it in the comments below, because it may well touch or help the next person watching. If you feel that this video prepared you a little bit more for your pregnancy and even your postpartum period, why don't you subscribe and join my waitlist below. And until my next video,